Our next speaker is Dr. Raghav Malik, who is from Center for Sight from Delhi, and he is going to be talking on secondary IOL implantation, gluing versus Yamane, in lieu of Dr. Sachdev Mahipal, who is at present tied up downstairs. Please,
Thank you,
Dr.
KC
Raghav,
sir, for
please.
this lovely opportunity. I will be speaking on glued IOLs versus the Yamane technique for secondary IOL fixation. Can I have my slides, please? So the indications for a glued or a Yamane would be intraoperative ZD or a capsular dehiscence, not allowing a PC IOL implantation or a traumatic cataract or subluxation in the absence of a capsular support, traumatic aphakia in a complicated cataract surgery. Muffins, of course, is a big indication. Subluxated or dislocated IOLs, we can, of course, glue or do the Yamane technique with the same IOL. Aniridia with the cataractus subluxated lenses, Wheel-Marchesani syndromes, ICE syndromes, and bullous keratopathy with or without an IOL exchange. So the technique is pretty simple. You make sterile flaps at 1 millimeter from the limbus, 180 degrees apart. The tunnels are created. A sclerotomy is made from where the IOL is inserted. And then once the haptics are externalized, under the flaps, you can make scleral pockets with 26 gauge needles where the haptics will be tucked in. Once they are tucked in, the fibrin glue is applied and the tunnels are closed, and hence the lens is stabilized. A quick video will show the same. So the advantage is that once the haptics are tucked inside the pocket, they are not going to move, giving a good stabilization of the IOL. Though we have seen late decentralization of the IOLs, but in 95% of cases, they seem to work very well. This is just a schematic video showing the same. This is how the scleral pockets are made. Then we make a flap from where the IOL, a multi-piece IOL, is inserted. The haptics are externalized, and once they're externalized, you make small tunnels. This is just the haptics coming out. You make small tunnels into the sclera with a 26 gauge needle where the haptics are tucked in, and then we apply fibrin glue and close the flaps. This gives us good centration, and patients seem to do very well. So the glue is quick-acting surgical fibrin glue derived from human blood, hemostatic and adhesive properties, composed of two separate solutions of fibrinogen and factor 1. And fibrinogen is activated by thrombin to form fibrin monomers, which actually gives the adhesion. So the advantages are that the same IOL may be fixed in some cases. There are no sutures, hence no suture complications, lesser surgical time, and no separate IOLs with eyelets that are required. You can go in with a simple multi-piece IOL. This is a case where we actually had to implant a multi-piece multifocal IOL using the glue. So this is a subluxated IOL. We attempted to do a cataract surgery and put an ECR and put an in-the-bag IOL. But of course, Murphy's law does come into action. You do the hydrosection, you do a cataract surgery, try and put in a PCR. We're doing a cataract surgery. There is a nucleus drop. And once that happens, of course, the putting a lens goes out of the window. We have to remove the ECR. Also, luckily, we could remove the ECR. We make the flaps, go in through the tunnels, do a vitrectomy, try and clean as much vitreous as possible. Remove the lens fragment, then put in a multifocal IOL, do a thorough vitrectomy, externalize the haptics, make pockets, and tuck the haptics in. Then once you do put in the glue, and that's it. This is the glue being put in, and the pockets are actually closed. This is a well-centered multifocal IOL. Similarly, we have similar experiences with Marfan syndrome. This is, of course, us going in from the pars plana, doing a vitrectomy and removing the bag IOL complex. IOL put through the flap, externalizing of the haptics through the tunnels. We make pockets and put glue. Good stable centralized IOL. This is a weak post-op. Intra-op complications can be trauma to the iris, dialysis of the iodialysis, hypema, or bleeding. Vitreous hemorrhage, the haptics may break on externalizing. Ideally, a 3-piece or a Prolene haptic should be used. Post-op complications, hypotony, CME, subluxation, RDs, and haptic extrusion, which do require a resurgery. The glued IOL in a complicated situations could be new innovation with fibrin glue for IOLs with no capsular support. It is safe, stable lens with no IOL tilt, faster surgical time with no sutures, no separate or different type of IOLs required. Long-term results are still under evaluation. Coming on to the Yamane's technique, yes, this is a transconjunctival sutureless intrascleral haptic fixation technique for secondary IOL implantation. It uses a double needle technique with a 26 gauge needle to create scleral tunnels. The IOLs are externalized with the handshake technique and flanged using a low temperature cautery, securing them in place. It is minimally invasive, reduces surgical time, and provides good stabilization. This is a quick video just showing how once the IOL is placed and the haptics are externalized with the cautery, the haptics stay within the scleral tunnels and give us a good centration and stabilization. If I quickly compare the glued and the Yamane's to compare and conclude my talk, the fixation with the Yamane is a scleral tunnel with flanged haptics. The scleral pockets with fibrin glue is used for glued IOL technique. So both are sutureless. The surgical time for the Yamane is definitely shorter. Stability is very, very good in our experience. The risk of decentration is much lower, and the learning curve is also flatter compared to the glued IOL. So to conclude, fixating a PCIOL using a fibrin or a Yamane technique is a viable option in patients with deficient capsular support, be it primary or secondary. And after an initial learning curve, excellent results are obtained in terms of stability of the IOL, centration, reduced CME, elimination of sutures, and lesser surgical time. Thank you.
Thank you very much, Raghav, for presenting Dr. Mahipal's wonderful lectures. Thank you so much. Sorry we kept you back. I know you are tied up just now.